My name is Sue Janzak, and I'm the Director of Strategic Marketing and Communications here at Health Integrated. And today I'm joined by Dawn Shivers of our marketing team to host today's event on motivational interviewing in integrated care coaching. It's very clear, judging by the enormous response we've received to this webinar, that this is a topic of intense interest, and rightly so, of course. People are unique. What motivates them to engage in care management programs should be unique as well, to be the most effective. No small challenge, right? But we know that health coaches that use motivational interviewing techniques with our integrated care coaching program boost member engagement and positive clinical outcomes that ultimately control costs. So by unveiling behavioral and social root causes and barriers to good health, motivational interviewing is the most successful tool for setting the stage to help drive improvements in personal health. More than 300 clinical trials have demonstrated this, as has our own experience at Health Integrated. So today, Dr. Sam Toney will be discussing the how-tos of motivational interviewing by meeting members at their starting point, identifying and removing barriers, and using assessments and interventions to help them back on the road to good health. A bit of background on our speaker. Sam is our Chief Medical Officer and Executive Vice President of Clinical Integrity here at Health Integrated, as well as a board-certified psychiatrist. What's more, he founded Health Integrated in 1996 in response to his vision and the growing need for sophisticated care management systems that address the medical, behavioral, and social health issues that affect patient care. Dr. Toney has designed and implemented a number of specialized behavioral health disease and case management programs across the country. He's served as the National Medical Director for large managed behavioral health organizations and has developed a chain of outpatient mental health centers and both multi-specialty IPA and primary care networks throughout the country. These experiences reinforced his belief that the integration of medical and behavioral care leads to the most optimal clinical outcomes and results in lower costs for payers. This innovative integration philosophy is at the heart of Health Integrated's DNA. Dr. Toney is licensed to practice medicine in 25 states and is board certified in psychiatry as well as in utilization review and quality assurance. Before we get started, a couple of housekeeping items that I just wanted to run through. We are recording today's presentation and will upload both the audio and the PowerPoint to our website by tomorrow. We'll also send you an email letting you know when that is available online at healthintegrated.com. To facilitate our presentation, all of our attendees have joined us on mute. Of course, we welcome and look forward to your questions, and we'll allow plenty of time to answer them. Please feel free to submit your questions through the chat box function throughout this webinar at any time. We'll collect them and answer them following Sam's presentation. Should time run out before he's able to answer all of your questions, we'll respond to each of them individually through a follow-up email. And with that, I'd like to turn it over to Sam to get us started. Sam?
Thank you, Sue. I appreciate that, and I appreciate the opportunity here today to discuss motivational interviewing, integrated care coaching, and member engagement. It's very timely and certainly has become a topic of great interest across the country. So to frame the issue, why motivational interviewing? Why integrated care coaching? What's so important and why now? Well, clearly we have a tremendous need in this country, a growing need around managing vulnerable populations, high-risk populations that are burdened with chronic physical illnesses. But to look at this and do this most effectively, I believe we have to look at the medical, behavioral, and social spectrum, the biopsychosocial environments of our members and the healthcare system in which they live and are treated. So all of this is about engaging the members, using specific tools, and achieving better outcomes, both from a clinical perspective as well as a cost perspective and certainly a member experience perspective. So again, as I said, we have a growing problem in this country, a growing population with chronic illnesses. In fact, more than 1 in 3 Americans have 1 or more chronic illnesses, and 80% of older adults have at least chronic condition, with 50% having at least 2. So this is a burden that the healthcare systems, whether you're a provider or a health plan, it really doesn't matter, is burdening the system with respect to access, with respect to management, with respect to growing rates of readmissions into inpatient facilities. It's an issue that we simply can't ignore and need to find the best possible tools to address. This is a particular study that I tend to use often. It's from the New England Journal. This is the right-hand side of the screen, which demonstrates the drivers of illness and risk. And this simply demonstrates that there's a very significant component of risk being driven by behavioral and social issues, just as much, if not more, than the genetic and medical and environmental issues. So at the end of the day, if we recognize what psychosocial burdens that our members are facing, we can more effectively engage them and then manage them to a healthier status of self-efficacy. This particular graph looks at the burden of depression versus non-depression in populations, whether commercial, Medicaid, Medicare programs. What we see here is that when populations are burdened with a comorbidity of depression, their costs tend to be higher. And these costs are all medical costs without necessarily the costs related to depression. So this is one particular driver. It falls within the psychosocial spectrum of risk and cost and mortality and morbidity. If we look at it with respect to behavioral health and not just depression as a specific example, we can see the similar types of trends. Looking at asthmatic patients as well as diabetic patients, we can see in populations of those who do have behavioral health comorbidities much higher cost and utilization patterns than we see in those populations without behavioral health comorbidities. And the orange bars here on this graph represent the behavioral health spend from a pure behavioral health provider environment, and the blue bars represent the total medical cost without behavioral health. So if we look at one particular example, depression again, as an example of a psychosocial burden in a population, it's important to know that depression goes way beyond an affective state. It goes way beyond just being sad or checking a symptom checklist. It certainly has negative impact on relationships, occupation, and recreation, but it also has a significant impact on one's biology. We have increasing bodies of literature now to indicate that depressive disorders can have impact with respect to a number of disease conditions such as diabetes, such as cardiac morbidity, and in fact has a higher risk for cardiac mortality. We believe there are links between, for example, serotonin transmitter systems and blood flow in the body, that there are serotonin receptors, for example, on the platelets, and there's something called serotonin-mediated platelet aggregation. So there's more than just what meets the eye with respect to these psychosocial issues and burdens. They can create higher healthcare costs, create contraindicated health behaviors, certainly productivity and functionality can be impaired, and certainly an increased healthcare resource utilization. So I wanted to talk for a moment about coaching. Coaching has become somewhat of a buzzword in the industry today. We talk about coaching, we talk about who the people are that should be coached and who the coaches are. And I wanted to create a quick table of comparisons between some of the more traditional modes or methods of coaching versus what we call integrated care coaching. First of all, executive coaching is typically rendered by an unlicensed individual or professional who helps clients find their way through transitional stages, such as career changes and improving relationships, work-life balance issues, and so forth. Typically, we identify individuals that are appropriate for executive coaching through referrals or direct outreach. And usually, in terms of assessments or interventions, there may be some questionnaires. The length of duration, here we reference 12 to 18 months. It can be very short. It can even be as short as 1 to 3 months. It depends on the nature of the assignment, and could be done telephonically or in person, usually on a monthly type schedule, with the targeted outcome being to increase effectiveness, as leaders. Now, with wellness coaching or even health coaching, we find both unlicensed or general licensure clinicians falling in this category. So might have nurses, we might have dietitians, nutritionists participating in this activity. Generally, we're talking about opportunities here to provide education and guidance to eliminate unhealthy behavior patterns such as smoking, help individuals with weight loss, and improve their nutritional balance. These are typically referral-based also, but we can also look at claims data to identify those individuals that might benefit from a wellness coaching and health coaching type activity. Generally speaking, there are questionnaires and some assessments that are utilized in this activity, and the duration of coaching might be anywhere from 6 months to 12 months, again with parameters around that which are shorter or longer depending on the particular situation. And the coaching frequency may be based on the individual's preference, usually telephonically, but can be done in person. And the ideal outcome here is to offer health and wellness coaching around personal goals and improving wellness status. But integrated care coaching is something a little different, and the approach here is to use clinicians with licensure in behavioral health, particularly master's prepared licensed behavioral health clinicians who understand not only psychopathology, but also how to utilize various cognitive behavioral and psychotherapeutic techniques, as well as motivational interviewing techniques. I'll say it here again, these techniques are very key to engaging members who are otherwise less likely to be engaged, less likely to participate, because it's understanding what the barriers are with these individuals and being able to effectively communicate with them to get them to engage in these types of programs. Usually the identification process is around claims-based stratification identification, but it can also be direct referrals from utilization management or case management as well, or even from the provider community. The assessments are usually much more detailed and take a deeper dive into the biopsychosocial spectrum of these members' worlds, and additional assessments that can be included, such as a PHQ-9, for example, for depressive disorders, or a mini mental status exam to determine cognitive capacity. A number of very specific assessments to understand where these members are in the course of their readiness to change, where they are with their psychosocial burden, etc. The coaching duration here also is usually between 6 to 12 months, with this being telephonically based and on a monthly or more frequent basis depending on the individual's needs. And the goal here is to use cognitive behavioral and motivational skills in combination with education and mentoring to help those individuals facilitate lasting behavior change and to reach a higher level of self-efficacy. So let's talk a little bit about integrated care coaching in specifics. What exactly is integrated care coaching? Again, it's a program or an approach that takes a much deeper biopsychosocial approach to helping individuals with their highest needs. These are typically individuals that are burdened with chronic physical illnesses, but who also have coexisting psychosocial burdens that prevent them from responding to treatment plans most effectively, prevent them from engaging in activities, and keep them in a higher level of risk and healthcare utilization. So this is an approach to help those individuals manage their behavioral health issues as well as their medical conditions by coordinating, facilitating care, to help those individuals make daily improvements in their behaviors and in responding to their provider's treatment plans, and assisting them in making long-term improvements. Again, it's focusing on individuals who have chronic conditions, usually more than one, and who have the presence of underlying psychosocial. And I want to make that clear. Psychosocial burden is not just about a definitive psychiatric diagnosis, and it's not just about a definitive substance use disorder. It can be maladaptive behavior patterns, certainly personality styles or disorders, any number of burdens that clearly are behavioral in nature, but not necessarily clearly psychiatric or addictions related. Again, what we're looking to achieve here are positive results for these members by addressing those psychosocial issues and empowering them to make positive, lasting changes. So we're talking about a coaching, education, support approach that supports and motivates individuals to improve their health status. These are individuals, again, with some level of psychosocial burden. Using integrated care coaches, again, who are licensed master's clinicians, to uncover the suspected psychosocial issue and then to coach to that and around that to achieve behavior change. Again, in our world, integrated care coaches are licensed Masters Prepared Behavioral Health Clinicians, so they come to us with an understanding of various issues in psychopathology, come to us with an understanding and training in psychotherapeutic techniques. Certainly cognitive behavioral therapy is a very big component in what we do in integrated care coaching, tied to motivational interviewing techniques. And again, they're used to support the biopsychosocial approach, so not to ignore the physical health aspects of any individual's needs, but to address those in concert with the psychosocial issues, even though they may not have a specific training for specific physical conditions. This is why physician oversight is important from both a medical and psychiatric perspective. So these coaches receive ongoing basic trainings on the chronic conditions that they encounter every day. They also receive training in cultural competency and diversity as well. So let's talk a little bit about motivational interviewing, and these are some basics on the approach and understanding the individuals that we face every day in coaching. Whether you're talking about integrated care coaching or wellness or health coaching, even in executive coaching, frankly, it's important to understand where a person is with respect to their knowledge of their condition and of healthcare and what their level of motivation is. So the first category of, and there are 4 categories here we're going to look at quickly, would be a low knowledge and low motivation. The adherence intention here would be categorized as low. So we definitely want to deploy motivational interviewing techniques here, provide specific education to increase that individual's knowledge level. For example, medication education. Many individuals don't understand the need for certain medications. They might use the side effects of medications as a barrier. So education around why the medication is critical and important to use is very clear here. We see this oftentimes in poorly controlled diabetics who don't effectively utilize oral hypoglycemics. So these are situations where education is critical. And using teach-back moments to ask members to repeat instructions and educate the family and support system as well. These are the toughest individuals to deal with because you not only have low levels of motivation, which need to be addressed, you also have low levels of knowledge. And I want to also point out that motivation can be low for many, many reasons. And it could be because there's a complication relative, let's say, to major depressive disorder, which can create low levels of motivation driven by the depression. So it's important to understand what drives that motivation as well as to understand where that person is. The next category is low knowledge but high levels of motivation. So the adherence intention here is variable. This is where education is very important. Motivational support here is given not so intensely because there's a higher level of motivation, but it's around education to the consequences, for example, of non-adherence, reinforcing that medication education and general education in general, discussing the actions before medications run out, for example. Again, teach back is important here, and education for family and support systems also critically important. The next category is high knowledge but low levels of motivation. The adherence intention here, again, is variable because even though there might be a high knowledge of what the circumstance may be, there may be low levels of motivation to change. Motivational interviewing here, very important. Remember, reminder systems important, social support plans are important, family motivational assessments are important. You might ask, well, who might have a higher knowledge level but low level of motivation? We often see this in the psychosocial spectrum of individuals who adopt the sick role, for example. Those individuals who have secondary gain to continue the sick role in spite of a higher knowledge level that it's not the best thing for them. But there is some level of gain from that. So understanding where that individual is relative to low motivation but a higher knowledge level is important to coaching them and using the motivational interviewing techniques and the psychosocial techniques that we'll be talking about in more detail. And finally, high knowledge and high motivation. The adherence intention here is high. These are individuals that are the easiest, if you will, but to support them, with continued knowledge and motivational reinforcement is certainly important. Open-ended discussions here are used to uncover any emerging concerns that might pop up along the way. So a more of a disease management, for example, approach here, just providing those individuals with reminders of the importance for adherence would be for someone in this category. So motivational interviewing in specifics is a directive technique. It's not an open-ended psychotherapeutic technique. However, in integrated care coaching, we do combine elements of psychotherapeutic techniques, such as cognitive behavioral techniques, in with motivational interviewing techniques in order to achieve the best outcomes. It's important for motivational interviewing sessions to be kept on topic, and respect from the patient must be earned. And one of the ways to do that, and this is also very clear in member or patient engagement, is to listen to the individual first and to understand where that individual is with respect to their goals, to have that individual define their goals for you as a coach. That, first of all, gains tremendous amount of respect, but it also it enhances the level of engagement significantly. And also creates an ongoing rapport with individual members that you have in coaching. Certainly, arguing is not the way to go here. It's important to align expectations and to ensure that respect is gained. Spend much less time, rather, giving advice and more time asking questions. Asking questions that are, in fact, going to elicit additional questions from the member, from the patient. So the provide-elicit model is key to success here, and that can be utilized to promote thinking, to promote changes in readiness to change, and actually behavior change. This can be used to induce something called dissonance, which I'll talk about in just a moment. But again, it's an opportunity to provide excellent change opportunities and to introduce suggestions for change. This is a common framework for motivational interviewing called the Reeds approach. We teach this to anyone involved in coaching, whether they're an integrated care coach or a case manager. Importance here is to roll with resistance, not to perceive resistance as a barrier on the coaching side of the equation, but to roll with that and to express empathy to that individual member, which will go a long way to building rapport and to facilitating change. Again, avoid argumentation that we mentioned as well. Develop dissonance, a real important tool in the motivational interviewing arsenal, and then to support self-efficacy along the way. Some of the tools that we use in integrated care coaching and psychosocial coaching techniques include decisional balance, planning, cognitive reframing, amplified reflection, etc. You'll see cognitive dissonance here listed again at the bottom on the left-hand side, a very important tool that care coaches can use to enhance recognition of an unhealthy situation and then promote behavior change. So a specific example then utilizing dissonance would be to consider a grandfather who has congestive heart failure, who's not able to play with his grandchildren because of shortness of breath on exertion, but yet this individual has not been adherent to the treatment plan directives, including diet, medication, and so forth. So the coach here is able to utilize, and this is a very simple example of dissonance, able to introduce dissonance. In other words, to point out a specific goal that is not able to be achieved because of a behavior that has not been adopted. In this case, the adherence to a treatment plan directive. These can get much more complex and frankly do very often get much more complex, and it takes a significant amount of time to induce behavior change. But I should point out that care coaching is while it takes on average 9 to 12 months to complete, each session generally takes anywhere from 35, 45 minutes upwards to an hour to complete. These are in-depth discussions and, again, not just about checking boxes. I wanted to talk about a specific program intervention that we've utilized here at Health Integrated called Synergy, Integrated Condition Management, and it employs motivational interviewing as well as the integrated care coaching we've been talking about. So I wanted to describe this program and then talk about the specific types of results that we can see from this coordinated effort. So this is a population management program that focuses on targeting those individuals within a population with multiple chronic conditions as well as those underlying psychosocial issues that can be either diagnosed or undiagnosed behavioral and psychosocial drivers. Again, this model is a telephonic model providing telephonic care coaching as well as local outreach coordinators to identify and engage members into this intervention. Again, this is a program utilizing not only motivational interviewing techniques, but the integrated care coaching model utilizing licensed behavioral health clinicians, typically master's prepared clinicians in the coaching initiative. As I mentioned before, this is a program that typically engages members up to 12 months, although some individuals are more complex and require more time. Others are less complex and can be reach a point of graduation, let's say, within 5 or 6 months. This does drive member satisfaction. It also has been demonstrated to improve HEDIS scores, which is something that we didn't anticipate in this endeavor, but independent study and validation has demonstrated that because there's an improvement in adherence to treatment, an improvement in self-efficacy, there's a secondary improvement in HEDIS scores as well as satisfaction with the overall health plan that that member belongs to. Obviously, our goal is to decrease unnecessary and avoidable hospitalization and ER visits and to reduce cost as well. The average return on investments for these programs can be anywhere from 1.5 to 3.5 to 1, and we'll talk a little bit more about that in specifics as well. This is a diagram that outlines how Synergy works. Again, the focus here is integrated care coaching with motivational interviewing, but it starts with identification. How do we know who to engage within a population? It's important to look for those individuals with chronic physical illness conditions, but who are suspected to have a high incidence of psychosocial burden. Now, it's impossible to know that definitively through claims data extracts, although we can use certain filters and algorithms to point out definitive psychiatric diagnoses, but we also have a means to look at utilization patterns and demographics to point out those individuals in the population that we suspect as having underlying psychosocial drivers. The real way to validate that, though, is through the engagement process, through the assessment process, in which we outreach to these individuals first through a mailing, introducing the program to them and letting them know they'll be receiving a call from their health plan, and then to reach out and actually have that discussion with the individual on the phone. This is where we validate the presence of an underlying psychosocial driver through that conversational assessment. It's a process whereby we first start out with inviting that individual to discuss their issues, to discuss their problems. What would their goals be in a program such as this? What could we be of help and assistance to them with? That is a very engaging discussion. At the same time, it's a discussion that allows us to validate and uncover psychosocial issues which may be at the surface or just below the surface. The next phase of this program is the empowerment phase. It is where the integrated care coaching and motivational interviewing take place. It's where the use of specific psychosocial tools and psychotherapeutic techniques are utilized to achieve behavior change that will be lasting and that will be meaningful and that will drive the outcomes that are in the green box around improvements in utilization, decreased levels of cost, improvements in satisfaction, and ultimately things like HEDIS scores, which have turned out to be a nice byproduct of this process. The bottom of this screen, just to point out, the Health Integrated Connect is the outreach, a community-based component of the program Even though this type of approach is telephonic, primarily telephonic in nature, there are feet on the street as well that work with high-volume providers to identify and locate hard-to-reach members and to work to engage them into the program as well. So even though the telephonic component is central, there is an in-person, on-the-street, field-based component to this as well. Just to talk about some of the types of chronic conditions that we see in an integrated condition management program, you can see a number of conditions at the bottom of the screen, all with what we would call modifiable variables. So most obvious type example in diabetes, where you have potentially an individual's capacity to manipulate their treatment plan. If, for example, if they're wanting to maintain their sick role and have secondary gain issues, certainly modifiable variables around diet, nutrition, around activity levels, exercise, certainly modifiable variables around adherence to treatment plans and medications. These are conditions that we typically encounter in an integrated condition management program such as Synergy. And we typically encounter more than one of these conditions in any given member. Typically, the average level of comorbidity is 4 conditions at any given time, because we are looking for the highest level of risk, the highest level of opportunity to enhance behavior change and create long-lasting outcomes. So in summary, for the Synergy program and in integrated care coaching, we certainly need to identify the population and look for those individuals that we suspect as having underlying psychosocial issues, but then to engage them through a motivational conversation to identify their readiness for change, and certainly identify their relative knowledge skills and identify what those specific problems are, and to implement motivational interviewing and psychosocial techniques to monitor their progress along the way as well. And so certain assessments that we may use, I referenced the PHQ-9 earlier, is utilized several times throughout the coaching experience to monitor improvement and change in that direction. Included in those lists are things like the post-traumatic stress disorder checklist, the mini mental status exam I mentioned earlier, a variety of tools and instruments that we've created internally as well to look for progress and goal achievement during the patient's or member's engagement in such a program, and then ultimately to reach a point of graduation where that individual then can move on beyond this program and achieve a higher level of self-efficacy. We'd like to talk about some specific case studies and outcomes now. And first of all, looking at some past results, and I referenced this on an earlier slide, looking at ranges of return on investment. One specific example is a 36,000 life Medicaid population in the Pacific Northwest that had a specific ROI savings, financial savings of $180 per enrolled or per engaged member per month. And they're in their 3 years now of this program, achieving an initial ROI of actually greater than 3 to 1, a sustained ROI of 1.5 to 1 in the 3rd year. A second example is the 55,000 life Medicaid program in New England, which demonstrated a $320 per engaged member per month saving in the 1st year of their program with a 3.5 to 1 return on investment. And then finally, a 20,000 life Medicaid population in the Great Lakes region demonstrated a 3.7 to 1 ROI in their 1st year of their program. I want to point out here that we're looking at financial return on investments. This is one aspect or one lens through which to look at a program like this. It's clearly important to look at satisfaction levels for overall health plan satisfaction rates. It's also important to look at HEDIS results, also important to look at changes in utilization. This is just but one lens to look through. And I also want to point out that all of these examples are all Medicaid populations, which have a very high potential for positive return and positive outcomes. But we have also seen similar results in Medicare populations and even in commercial populations where the subset of the at-risk population may be much smaller, but we certainly can find the opportunity in all populations, doing the appropriate data mining and doing the appropriate identification. That's what really this is about. It's not about a population-wide or disease condition-wide approach. It's a very targeted approach to look for specific opportunities for improvement relative to psychosocial burden. And that's the key differentiator, I think, between, let's say, case management or other disease management or health coaching activities. The selection methodology in terms of how to select an individual that may be appropriate for a program like this is critical. And again, we look at claims data sets, but then at the end of the day, once we've identified and managed a specific cohort, it's also equally important to then match the results from the managed cohort with a matched population, matched subset of the population from the same plan. So we're looking then essentially at control groups or comparison groups who are matched on age, gender, disease burden, cost, utilization patterns, and something called momentum index. I don't have the time to go into the detailed discussion around momentum index, but essentially think of momentum index as a proxy for disease onset and disease progression. When an individual is diagnosed with a certain disease, the progression of that disease state relative to peaks and valleys of utilization. So we want to be able to compare like members with like members within the population so that we can adjust for any type of regression that we might see in utilization patterns. This is why it's so important to look at a number of variables against which we match. This is a quick graphic representation of looking at comparison groups and cohort managed groups, both starting out in relatively the same place prior to member engagement, but then post-member engagement and graduation, we typically see some divergence in the comparison group and managed cohort groups. And it's not always this particular pattern. We certainly may see some regression in cost and utilization in the comparison group, which is the blue bar. But we typically see a much higher level of decrease in utilization and cost in the managed cohort group, which is the green line. So again, this is addressing regression that can certainly be present in any population. We tend to see regression being a bit lower in these high-risk populations because they're not general populations. They are not, in fact, they're not just a population of diabetics or asthmatics. They are a population of diabetics, asthmatics, and a variety of disease states with psychosocial burden, which makes them a bit more challenging to engage, more challenging to coach, but a potentially higher level of return at the end of the day. This is also another graphic representation of the valuation methodology to compare changes in utilization, not just cost, but utilization between a managed cohort and a non-managed comparison group that's, again, matched against a number of variables. And what we look at here are similarities on the left side with the inpatient admissions, and we can see both starting out around 600, but a much sharper decrease in the inpatient admissions for the managed group. Same thing with the ER visit rates. We see a slight decrease in the ER visit rates of 1,200 or so in the non-managed comparison group, a much sharper decline in the ER visit rates in the managed cohort group. So again, we're not only looking at dollars, we're looking at utilization rates, and we also have a third-party validation in comparison of HEDIS results, which we'll talk about in just a moment. I want to talk about a specific case study. What happens with a specific individual who enters a program like this? What are the various conditions that are identified? What are the psychosocial issues that are identified? What are the specific motivational interviewing and psychosocial cognitive behavioral techniques that are used, and what are the outcomes? So this is a specific sample case we have of a 65-year-old male who was identified through claims data mining. This individual was identified with coronary artery disease, hypertension, chronic back pain, and diabetes. Probable diagnoses that were identified through coaching were depression, and this was not identified on the claims data extract. There was no definitive diagnosis for depression, but through as you'll see in the issues, a PHQ-9 score of 20, which indicates a relatively severe level of depression that was identified by the integrated care coach. Also as an issue, low activity levels due to back pain, less than optimal eating habits with high sodium intake and high carb intake, decreased energy levels, poor motivation, insomnia, maladaptive coping behaviors, as well as fluctuations of blood pressure and hemoglobin A1Cs. This member was engaged for 10 months and had a total of 12 coaching calls by the coach. The results that we saw with this individual through the use of cognitive behavioral integrated care coaching by the master's licensed behavioral clinician, the techniques that were used here included agenda mapping, which is to focus the member on consideration of the plan to manage his health conditions, reframing, which supports more positive perspectives regarding dietary changes and the results of those dietary changes, implementation intention, which was to formalize the commitment statements about improving his health status, amplified reflection, which was to highlight the value of the member's self-management actions taken to help cope with those low energy levels and depression as well as chronic pain, and consciousness raising, which was to work to increase this individual's awareness of his health status through nutrition and exercise information. There was also an additional intervention done here, a doc-to-doc interface with the primary care physician of record to identify that this member more than likely has a depressive disorder and share that information with the doc. The attending physician then elected to begin sertraline, which is an antidepressant that was first started at 50 milligrams a day and then increased to 150 milligrams per day. The results in this member after the duration of coaching was to show stabilization in blood pressures and hemoglobin A1C by May 20th, which was towards the end of the coaching. There was also initiated a consistent fitness plan by walking and daily reports, as well as that his clothes were fitting better, for example, improved diet by decreasing salt, and implementation portion control and not eating after 7 p.m. The results were also a reduction in the PHQ-9 score down to 7, significant reduction. Also, we were able to identify major depression as a diagnosable comorbidity, which also had an impact on this individual's HCC risk adjustment scores. So a significant finding and an outcome as a result of the coaching effort. And then a risk of cardiac morbidity and mortality reduced through effective antidepressant treatment. I think most clinicians know that cardiac disease, coronary artery disease, bears a high risk of morbidity and mortality when depression is present, both from a pre-MI and post-MI perspective. So in this instance, we were able to achieve some very positive outcomes. We saw changes in ER utilization patterns with this individual. 4 ER visits prior to engagement in the program, no ER visits post-engagement, 2 inpatient admissions prior, and no inpatient admissions post, and a significant reduction in the per member per month cost for this individual. A specific reference now I'd like to make to Care Oregon, a Medicaid plan in the Pacific Northwest in Oregon with 46,000 Medicaid, 2,000 Medicare Advantage members. This was a particular case study in which we deployed our Synergy Integrated Condition Coaching and Care Management Program with the telephonic motivational assessments and interviewing conducted by our licensed master's behavioral clinicians. We also did deploy a field-based outreach coordinator who's also clinical in nature, clinician by nature, to work with providers and community supports. Again, what we saw with this particular population, inpatient admissions declined by 14%, emergency room utilization declined by 8%, a result of 2.25 to 1 financial return, but also significant results and improvements in HEDA scores and satisfaction surveys. And this third-party validation, which I just referenced, was conducted by Portland State University at the request of Care Oregon, and actually unbeknownst to us in Health Integrated. So the results were revealed to us after the study was completed. The study engaged Portland State to conduct surveys and interviews and to perform data analyses on the entire population, as well as those individuals that were coached in the Synergy program. Data from the two sources include patient surveys and HEDIS data that was provided by the health plan. What we saw then, and just a quick note here, that members who participate in the program have better rates in nearly all measures examined. This was something that we were pleasantly surprised to see, although when one considers that an individual's adherence and overall self-efficacy is improved through coaching, then it stands to reason that changes in things like HEDIS scores as well as satisfaction also improve. These are some specific HEDIS score results that we saw in comparing all of Care Oregon with the members that were in the Synergy program. And the Synergy program, I failed to mention, has two components to it. One is a coaching component where the care coach works directly with that member telephonically on regularly scheduled calls. The orange bar is labeled Synergy Mail only, but that's actually a bit of a misnomer because it's a self-coaching component of our program, which includes mailers. It also includes IVRs. It includes a number of other interventions. When that member is not yet quite ready to speak and engage with the care coach, they enter into a self-coaching track, and it's part of the cohort. But here, Portland State University separated the populations and looked at only those individuals who had the self-coaching track versus the coaching track. And what we see here on the various HEDIS metrics are a significant improvement in performance for those individuals in the coaching programs versus those who were not. Similar results were seen in a matched comparison group when looking at financial and utilization results, as I pointed out earlier. So here we clearly have improvement in clinical outcomes looking at HEDIS results. And if we go to the next slide, we also see some nice results relative to satisfaction. The next to the last bullet, for example, here, overall satisfaction with coach and impact, 96%. The health plan believes that these levels of satisfaction also translate into overall health plan satisfaction, which certainly can be a great value in things like CAP scores and in star ratings. So we believe that when engaging a population effectively and appropriately in a targeted way, looking for those individuals who have high risk of health burden and psychosocial burden, and improving their outcomes, improving and enhancing satisfaction levels, the results and the value from that are multifaceted and multifactorial. With that, we have a few minutes for questions, and so I believe we received a few here. So we will open up that discussion at this point.
We have. Thank you so much, Dr. Tony. And it's very clear that when taking individuals' health into consideration, you really have to look at all dimensions of their health. Biological, social, psychosocial, making sure that you address it from end to end. And ultimately, for payers, it really helps them address the triple aim, whether from quality of care to the care experience to their bottom line on per capita cost. So we do have a couple of questions. The first question that came in, does motivational interviewing work as a coaching method for individuals with behavioral or psychiatric diagnoses?
Yes, actually, in fact, what we've been talking about here primarily are those individuals with psychosocial burden. So many of them do have definitive psychiatric diagnoses. And in that instance, actually, this technique can be more powerful because the use of motivational interviewing techniques coupled with what I would call psychotherapeutic techniques can then leverage a higher level of adherence and behavior change. It's important to know that what the coaches are doing is not formally the delivery of care. It's not a formal rendering of care such as you would find in a telemedicine or telepsychology or telepsychiatric environment, but there's a fine line. And the fact that these coaching sessions are being rendered by licensed masters prepared psychotherapists, I certainly believe they have psychotherapeutic value, but again, not formally considered or categorized as psychotherapy.
Okay, very good. In your experience, are medical nurses effective in using motivational interviewing techniques?
Yes, absolutely. I think that, like in anything in medicine, the intensity of the treatment needs to match the severity of the illness. And so in that instance where we have medical nurses, med-surg nurses in case management, in fact, many of the CMAG guidelines that some of you may be familiar with have strongly endorsed motivational interviewing in case management. I believe that's very valuable. Motivational interviewing can be helpful just about in any interaction with a member or a patient. However, there are degrees of specificity, degrees of intensity, and I think that when dealing with more complex members, for example, the member that I referenced earlier, the member who has diabetes, depression, and then some level of secondary gain from maintaining that sick role, that becomes a much more complicated member to deal with, and I think the need for a higher level of intervention and understanding of that psychopathology is needed. But to answer the question, absolutely, I do believe that med-surg nurses are very capable of learning motivational interviewing techniques and utilizing them in every instance.
Okay, great. Very, very early on in your presentation, you briefly mentioned readiness to change. What is your perspective on Prochaska's trans-theoretical model?
Yeah, you know, we didn't mention the trans-theoretical model in specifics, but it certainly it plays a role in identifying readiness to change. It is something that we incorporate in terms of identifying where a member is along that spectrum. I think, though, that we take it to maybe another dimension, and that is to not only look at someone, let's say, for example, as being contemplative in terms of their relative readiness to change, but why are they contemplative? Is that level of contemplation secondary to, for example, a state of generalized anxiety disorder? Or is it relative to a certain personality style or disorder that they may have? So as important as that trans-theoretical model is, and to understand where an individual is, it's equally important, if not more important, to understand what the drivers of those levels. For example, two people can be contemplative, but can be contemplative for totally different reasons. One person may be contemplative relative to an environmental issue or family support issue or social support issues or peer pressure, whereas the other individual may be contemplative due to a major depressive disorder. So it's important to understand what drives those levels and readiness levels of change.
Good distinction. Very good. And we have two questions that are specific to the Synergy program. One, do you do any follow-up with your graduates to assess sustained behavioral changes and or relapses? And if so, is this done via personal contact or claims mining?
Oh, that's a great question. The answer is yes, but it is done primarily through claims data mining. So we will follow cohorts through. Frankly, we've got some cohort data that look at members even 2 years post-graduation. And what we see in those cohorts are sustained improvements in the utilization patterns and the cost patterns. We don't follow up with those individuals directly. However, we do invite individuals to re-engage with their coach if they need to at a later date after graduation. And we've had a few instances of that. But what we've seen more often than not is a sustained period of improvement in terms of utilization and cost following these cohorts of members through claims data mining.
Very good. And one more on Synergy. Has the Synergy program been tried with children and their caregivers? And if so, has it been successful?
It has not been tried or implemented with the children with pediatric population. There are some varying levels or varying schools of thought on that. I believe there's certainly an opportunity to demonstrate clinical improvement with those individuals working with their parents and caregivers. It's sometimes difficult to be able to demonstrate financial ROI with those populations because the cost burdens are typically lower. But it is something that we have entertained. We have created the business intelligence, the creative clinical business intelligence around managing those populations, but we have not yet embarked on that particular population.
Okay, very good. One more question. How important is it that the individual providing the integrated care coaching be a licensed professional? What do you think about peer support?
Peer support is very important and very valuable, and I think has its place in this continuum of coaching. I think that when it comes to understanding and diving deeper into those psychological issues that some of these members are burdened with, peer supports and peer coaching might be a little challenging to complete. I think peer coaches, as part of the continuum, as part of the team, as part of the integrated care coaching effort, is absolutely appropriate, and I would applaud any efforts along those lines. We have not at Health Integrated particularly taken that path, but would be certainly supportive of any plan or any community that deploys that peer coaching in conjunction with a specific targeted psychosocial coaching effort.
Okay, very good. Actually, I see that we are at time, so for the couple of questions that we have, we'll make sure that we do follow up direct responses for those, so thank you very much. And thank you for everyone on the line for joining us today. As we mentioned at the beginning of the call, we had an enormous response to today's webinar in terms of registrations. So as a result, we will broadcast today's webinar in its entirety 2 more times. One, Wednesday, April 3rd at 2 p.m. Eastern Time, and again on Wednesday, April 10th, also at 2 p.m. Eastern Time. As a reminder, we'll also be posting the webinar to our website no later than tomorrow morning. And one last note, please join us again next month when Colleen Heffernan, the manager of case management here at Health Integrated, will be presenting best practices in case management, and that will take place on Wednesday, April 23rd, also at 2 p.m. Eastern. Please watch your emails and our website for registration information. And with that, this concludes today's webinar. Thank you all.